We thought about from the nursing standpoint, what is our goal for doing this? What we wanted was first, education of the patient, right? Can we successfully educate the patient to prepare them? Can we alleviate as much anxiety as possible so that they feel comfortable coming in and having this done? The second one was to preserve kidney function throughout the treatment. To date, we've been successful with that. And the third one is to complete the treatment without infection.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Chris Amoroso, registered nurse at Fox Chase Cancer Center in Philadelphia, Pennsylvania, about nursing considerations for intrarenal administration of anti-cancer treatment in upper urothelial tract disease. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation that we have linked in the episode notes. Welcome. Thanks so much for joining us today, Chris.
Thanks for having me. Let me share my information with you guys.
Wonderful. Well, I'm excited to talk about this. Certainly a unique topic that I know that I'm not very familiar with, so I look forward to learning. Let's start off with a description about what exactly upper urothelial tract disease is, and then maybe explain why the process for treating it is a little bit different than from maybe something we're familiar with, such as non-muscle invasive bladder cancer.
Non-muscle invasive bladder cancer is in the lining of the bladder. This is actually upper urothelial tract carcinoma affects the renal pelvis, which is the kidneys or the ureters. So it's rare. It doesn't account for a big part of urothelial carcinoma. It's basically about maybe 5% or so. And it's a little bit harder to diagnose. When you go into an office or an operating room and you do a cystoscopy, we can visualize the bladder wall. We can see if there's anything there. But with upper tract disease, unless you're in an operating room setting, to get up into the ureters, to look into those ureters, it's an uncomfortable position for the patient to be in. So as in an office setting, it's not something we can really visualize. Patients will present with hematuria or flank pain, maybe obstructions in the ureter, some hydronephrosis, maybe having a lot of urinary tract infections. And a routine cystoscopy in the office is not going to visualize the ureters. So it's a little bit harder to visualize that. We can do biopsies like a ureteroscopy, a CT urogram, like visualization of the kidneys, the ureters, the bladders, or urine cytology. And that's usually the main ways of diagnosing the upper tract disease. Again, because it's rare, it's not visually there when you're looking at a routine office flexible cystoscopy. We do rely on urine cytology a lot when we're doing our office cystoscopies to look at that urine cytology to see if there's anything that's not visual to the naked eye that could be coming from the kidneys or the ureters. The treatment's different when we have someone with non-invasive bladder cancer, non-muscle invasive bladder cancer. We can treat that locally by using medications such as we use BCG a lot, putting a catheter into the bladder, instilling the medication and doing like a bladder wash, but that's not going to hit the ureters. So these lesions that are higher up outside of the bladder into the ureter, traditional intravesical or into the bladder treatment is not going to reach this area. And also one of the challenges that the surgeons have is that these lesions in the ureters are not easily resected like they are if they're on the lining of the bladder wall. The bladder wall, you can go in and resect them out, but in the ureter, you really can't go in and just resect out little tumors. So it's, a little bit more challenging to diagnose, a little bit more challenging to treat. But we've done it and we've been pretty successful with this treatment, approaching it from an antegrade, right? So going above the bladder to treat these lesions that are in the ureters.
Wonderful. Thank you for that. That really helps me kind of visualize what we're talking about, where in the body we're talking about. And I think, again, comparing it to something that might be a little bit more familiar of that non-muscle invasive bladder cancer, a little bit of familiarity with the intravesical administration like you referenced. And so knowing this is actually, like you said, antegrade coming from a different direction. So let's talk a little bit about the actual administration process. What does that process involve? And maybe just provide an overview of kind of start to finish what that procedure looks like.
It's given as the same schedule as typical or traditional intravesical therapy, where we're doing an induction course, which is once a week for 6 weeks. But prior to that, we need to do a couple things. About 2 weeks before we start the treatment, we have an educational session with the patient. We ask them to bring a support person with them. If they can't come in person, we'll do it over the phone. But in that first initial contact with the patient, we'll go over what the schedule is going to be, what their day is going to look like when they get here, but also to let them know that a week before we start the treatment, they need to have an appointment in our interventional radiology department to place the nephrostomy tubes, because this is going through nephrostomy tubes. That's how we're delivering the medication. So we're hitting those areas from above and let it work its way down the ureters to hit those areas of concern and then into the bladder. So about a week before we start treatment, the patients have an appointment in interventional radiology. At that initial educational session, about 2 weeks before, we're setting up the days and the time that's going to work for the patient. We pick a day, we keep it the same day every week and the same time for consistency. So again, the patients are involved in an educational session about 2 weeks before we start. They have an appointment in interventional radiology a week before. Nephrostomy tubes are placed. We're teaching them what to do with the nephrostomies, how to care for the nephrostomies, and what to look for that might warrant a call to their care team, whether it's the nurse or the doctor. Things like if the nephrostomy tube has redness around it, if the insertion site is warm, if there's leakage, we would need to know that before we get started, because that would not allow us to give the treatments. On the day that the patient arrives for their first treatment, we bring them in, we ask them to lie back on a stretcher. They're going to be laying there for about an hour or so. The infusion takes an hour. But prior to that, the patients have to empty their bladders first. We visualize the urine. We're looking for, is there any blood in there, any presence of hematuria, any symptoms of urinary tract infection that the patient might be feeling, burning or pain with urination. We're inspecting that insertion site of the nephrostomy tubes. Again, is there any redness? Is there any drainage? Does the patient have a fever? These are things that would defer the start of treatment. Again, patients void before we get started. We want an empty bladder. We ask the patients to get into a comfortable position where they can sit for about or lay for an hour without too much movement. The movement of their body position can interfere with the flow of the medication going in. Before we get started with the actual infusion, we are going to gently flush the nephrostomy tubes with 10 milliliters of sterile saline. Again, looking to see, is there any resistance, any leakage? Does the patient report any discomfort? Our infusion pharmacy over at the hospital, again, we're at a satellite office about 5 blocks from the hospital. So our infusion pharmacy prepares the medications, and then we have a courier service that brings it over to us. When we're ready to start, we're cleaning the ends of the nephrostomy tube and the IV tubing with a chlorhexidine solution. We're instilling this using micro drip tubing. The tubing has to be micro drip so we can accurately control the flow. The IV bag with medication is hung about 10 inches above kidney level. And the reason we do that is because we do not want to increase the intrarenal pressure. So it's by gravity, never on a pump, because you can damage the kidney. So about 10 inches from the level of the kidney. And we want to instill it at about 1 milliliter a minute. So that'll get us to, that 60-minute infusion. We want a slow infusion via gravity over about an hour. It's mixed in a 50 milliliter bag. So that's about an hour to instill. We're watching throughout the procedure to make sure that there's no leakage, no discomfort, really just watching the patient and having that communication with the patient. Are they feeling anything different? Do we notice a difference in the flow rate? Is it slowing down? And if so, why is it? Did the patient change position? If we have any of that where the patient says, I can feel something there, or we see leakage, we stop that infusion immediately. And again, emphasizing it has to be gravity, never on a pump. And again, we're trying to avoid that increase in intravenous pressure. So the infusion will go in slowly over an hour. At the end of that infusion, we're going to let the drug clear the tubing by placing a 50 milliliter bag of saline and just letting it slowly go in about 50 mLs or about 15 additional minutes to clear the medication from the tubing. We are not flushing the tubes at the completion of that. We don't want to quickly clear the kidney and by giving that quick flush. So we'll do that gentle flush over about 15 minutes, just enough to clear the medication from the tubing to make sure they're getting the full dose. Now, we have our infusion pharmacy actually prime the tubing. We're trying to keep it as much of a closed system as we can. So, pharmacy is wonderful with already priming the tubing with the medication. And for the purposes of this talk, I'm going to just talk about BCG. So, the only drug that we have treated patients with is BCG. We have not treated with chemo. It hasn't been warranted. So, chemotherapy we have not done, but we all of our treatments up to this point have been with BCG. So pharmacy mixes it, primes the tubing, and sends it over to us. After the infusion's done, we've let the gentle flush of that 15 mLs through this second normal saline bag go through. We're going to cap the nephrostomy tube or tubes with a clean, sterile cap. We're going to dispose of all the equipment in the chemo container waste like we would normally do into the bins, put a new dressing over the insertion site, and then we have the patients to hold their urine for about an hour. When we give intravesical treatment, we like to have a dwell time of 2 hours in the bladder. So we account for the infusion time of an hour and then a dwell time of an hour. So to give that 2 hours total. So patients void before the start of the infusion. We infuse slowly over an hour. We ask them to hold their urine for another hour before they urinate. This is done once a week for 6 weeks. And at the end of those 6 weeks, we will arrange for a visit appointment in interventional radiology to have the nephrostomy tube or tubes removed.
Wow, Chris, that was an amazing description. Really helped me again to visualize and kind of just walk through the whole procedure kind of from start to finish. So thank you so much for just that comprehensive overview. You did sort of mention tube or tubes. So do we typically just do this with one tube or is it bilateral or what changes that?
Up to this point, we have treated patients with bilateral disease. So patients that have lesions in both of their ureters. So we've done bilateral infusions. We've actually treated a patient who has a solitary kidney. So we have one tube and, really nervous sometimes with that one because they have one kidney and we definitely want to preserve that kidney function. We actually are treating someone now who had an ileoconduit. So he has now disease in both of his ureters. And so we treated him through nephrostomy tubes bilaterally and had to kind of hook a little makeshift drainage of his ileoconduit to capture that drug as it exited his body. He did have some discomfort with the nephrostomy tubes coming out of his flanks. So when he came in for his surgery to evaluate the response to this, the surgeon consulted with myself and the other nurses that do the infusion to inquire, what do you think if we were to internalize the nephrostomy tubes and have them exit through his ileoconduit stoma? And that's what we do now. So this gentleman, who is a wonderful patient, he has an ileoconduit, and through his stoma, the nephrostomy tubes are exiting through his stoma and into his ileoconduit drainage bag. So for him, we'll hook the IV tubing up to his nephrostomy tubes that are exiting his stoma. And he has had a much better experience without those external tubes coming from his flanks. So we've done this in various different ways, depending what the patient needs.
This is most I've ever learned about intrarenal administration in one setting.
Oh, so much to learn.
There is so much to learn. And as you said, it is rare. It is not something that the average oncology nurse in the average setting might see a lot or at all. So I think this is just so important for us to understand and talk about. So when we do care for a patient that needs this type of treatment, we have this information to start from. So this is really wonderful. I also appreciate you clarifying that you're specifically administering BCG in your discussion today. So again, that we should be following safe handling procedures, but also there's the added sort of layer of sort of these biohazardous viral precautions that come with administering BCG.
And that is part of the educational session that we have with these patients about 2 weeks before the start of their treatment. We go over all the BCG precautions because this is the drug that we're giving. So as if we were doing traditional intravesical therapy, placing a catheter up into the bladder, we're still giving them BCG. So we need them to follow that special precaution. So every patient, regardless of the drug we're giving them, we ask them to sit down to urinate, pour 2 cups of bleach in the toilet, let it sit for about 15 minutes, and then to close the lid, flush twice. So, even though we're giving this for upper tract disease, it's still being excreted into the urine. So precautions need to be followed. So, sitting down to urinate to avoid splashing of the drug, putting the 2 cups of bleach in every time they urinate for a duration of 6 hours, closing the lid, and then flushing that toilet twice. The same precautions, whether it's traditional intravesical or intrarenal.
Wonderful. Well, let's talk a little bit more about some of those pre and post administration considerations. What should nurses keep in mind kind of before and after the administration procedure?
One of our biggest challenges or considerations is, again, that we are not located at the hospital. We're about 4 or 5 blocks away in a satellite location. So if anyone is familiar with BCG, they know that the stability, once reconstituted, is 2 hours. So our pharmacy mixes it up. We did enlist a carrier service to transport this over to us. That cuts into the time that we have. So before that drug gets here, we need to make sure that we have everything we need to get started. Being a satellite facility, we need to make sure, do we have the right tubing? Do we have the proper personal protective equipment? Do we have the proper flushing solutions? Do we have caps for the nephrostomy tube? These are things that, not being in a hospital setting, we need to make sure we have on hand. We can't go looking for everything beforehand. So all that personal protective equipment, so the gown, the gloves, the mask, the goggles, all that, making sure we have the normal saline flush bags. Again, we are a urology office. We do procedures here, but we don't use normal saline bags. So we need to make sure we had that. We need to make sure we have the proper tubing. So just making sure we had everything we need to do. And also coordination with the infusion pharmacy at the hospital, with the carrier, with the patient. Again, we have a 2-hour window from the time it's reconstituted to have this infused into the patient. So we do go over with the patient this information, and we give them a number to call. If something happens, they're going to be late, they need to notify us right away. Their car doesn't start, they're not feeling well. We need to know that right away so we can communicate with our pharmacy. Again, it's a very short window of viability for the drug once it's reconstituted. So that was a big consideration with being a satellite office doing this procedure.
Well, and as you're describing this, like, there are clearly so many moving parts to this procedure and how to just align logistically all the things that need to happen kind of leading up to and then after the actual administration. So what are some of the sort of tips that we as nurses need to know so that we can educate and prepare our patients and their caregivers and support members? What do we need to be able to tell them so that we can keep things moving like you've just described?
Patient education is key. I think they are the biggest part of this. The most important part is that they understand that all their questions have been answered. Any areas of concern that they have, any concerns, that we address them before they arrive that day. Again, we do an intensive teaching session, and we encourage them to have someone with them. They're being hit with this diagnosis, and now here's how we're going to treat it. It can be overwhelming. So we do really encourage having a support person with you, whether, again, it's in person or on the phone. So we go through everything. So make sure you have your educational materials available, that you have all the information for the patients, a schedule printed up for the patient. We go through an educational session, and then we follow up with printed information that we send to the patient, our phone number, contact person, review this, make sure everything we told you makes sense. If there's any questions, and we answer it ahead of time. And also making sure that the patient has what they need at home. Something as simple as having bleach. Do you have the bleach that you need? Do you have new caps for the nephrostomy tubes? When we do this procedure, it's individual physician preference whether the nephrostomy tubes get flushed on a daily basis following treatment. Some physicians want their patients to flush daily, and some do not. So we want to make sure, do they have what they need to do that sterile flushing every day if that's what the doctor orders? Do they have dressings at home? Things like that. Making sure that they have what they need and that they have a clear understanding of what's going to happen, who to call in the event of an issue. And we go over what issues they're looking for. If they have the flu, if they have flu-like symptoms, fever, chills, if they think of a urinary tract infection, if they see blood in their urine, what are they going to do? So as nurses and care professionals doing these treatments, we need to make sure that we have all of our information correct. We need to have a huddle. So the way we did it here at Fox Chase, when we did our first installation, we had a pre-installation huddle with the staff, going over, do we have everything we need, communicating with the pharmacy, arranging for that time for them to reconstitute the medication. And again, what questions does everybody have? Is everyone on board? And then following the installation, we had a second huddle. What went right? What went wrong, if anything? Is there something we can do different? So communication is key, making sure that all the players are involved. Our physicians here are amazing. And I will give a big shout out to our manager, Rebecca. She was key in getting this all going. We can instill it as nurses, but to actually get to this point where we have this protocol in place, I have to give her, 99% of the credit. She's amazing. She has a lot of experience she brings, but we also have a really great team of doctors, clinical pharmacists. It's just the nature of Fox Chase Cancer Center. We all know each other. We communicate well. We all have a great respect for each other. And so really working as a team to make sure that this is successful and as smooth for the patient as we can be.
I love that. Really just again highlights that oncology is a team sport. It's a team sport. Everyone,
it absolutely is. Yeah.
Everybody has to get off the bench and play. And so I say that jokingly, but it truly does show that we all have our role, but there are some times where we can't do our part without others doing theirs. And so
absolutely,
really just a great sort of a showcase of how important that teamwork and that communication piece really is for these more complex or unique administration procedures. So it's just great to hear how your team collaborated together on that. So when we do administer this treatment, what would you say are the goals, or how do you define sort of a successful administration?
Right from the start, we thought about, from the nursing standpoint, what is our goal for doing this? What do we hope to accomplish for the patient? And I can tell you that what we wanted was, first, education of the patient, right? Can we successfully educate the patient to prepare them? Can we alleviate as much anxiety as possible so that they feel comfortable coming in and having this done? So again, education is supporting the patient, number one goal. Can we get the patient through this and alleviate some of their anxiety? The second one was to preserve kidney function throughout the treatment. Going back to the installation, never on a pump 10 inches above kidney level to not create too much of an increase in intrarenal pressure. So our goal for a nurse was how to preserve that kidney function. And to date, we've been successful with that. And the third one is to complete the treatment without infection. Whenever we're doing invasive procedures, whether it's traditional intravesical treatment or the intrarenal, can we do this and not cause an infection? And we have been successful in that. Again, making sure that we have the proper equipment, that we are cleaning things, that we're assessing prior to installation and infusion. Just really the main goals, again, education, preserving kidney function, and not causing an infection, and getting them through their treatment safely.
In terms of the length of the treatment, the procedure itself, what are some of the complications that we might be watching for as a clinician during that encounter? What should we be watching for? Kind of how do we identify them? Maybe how do we either address them or mitigate them during the actual administration procedure?
The treatments are given what we call the induction. The induction phase is the first 6 installations. So the first time we give this drug, we're doing it once a week for 6 weeks. And during those 6 weeks, we're communicating with the patient. We'll do a follow-up phone call. How are you feeling? Any issues? And we do get to know our patients really well. So they feel very comfortable calling us saying, hey, I'm not sure about this, but having a little burning with urination. If they call, we're going to send them for a urine culture, make sure there's nothing there. I saw a little bit of blood. First thing is very hydrating enough. So after treatment, our goal is to get them to drink 1 liter a day. Not always possible, but that's our goal. So again, induction is once a week for 6 weeks. After those 6 weeks, we're making sure the patient understands that this is not one course and done, that we want to continue to do this to give them the best success at preventing recurrence. So after we're done those 6, we'll wait a couple weeks, probably about 4 to 6 weeks, and then we'll do a cystoscopy, ureteroscopy in the operating room to make sure we have the response we're looking for. Again, letting the patients know, because sometimes they don't have an understanding that this is going to continue on. It's not 6 treatments and done. A lot of patients will make a comment, oh, I only have to get through these 6. And we have to make sure they understand that you'll get these 6. And if you get the response, we're going to do more. We're going to do maintenance courses. So we'll do maintenance courses about every 3 months. It's once a week for 3 weeks. So we'll do the first 6 induction, do a visualization with ureteroscopy, and just look and see, are we getting the response you want? If so, we're going to do 3 more treatments in about 3 months' time. So these patients need to understand this is for the long haul. Maintenance can be anywhere from 1 to 3 years based on the BCG availability. For those of you out here who don't know, there's been a nationwide BCG shortage for years now. And so sometimes maintenance can be based on the availability. Here at Fox Chase, we've always been able to continue treating patients. Our pharmacy works really hard to acquire this drug. But right now, we're doing maintenance for about a year or so. About every 3 months, we're giving 3 treatments. And the patients, I want to make sure they really understand that. If they see blood, if they think they have a urinary tract infection, if they have fever. And here's a big one. We started these treatments in 2020. And guess what? Then COVID happened. So what do, right? So along with the BCG shortage, now we have COVID, which impacted our ability to treat patients. Our physicians were doing a lot of telemedicine visits, but we can't do intravenous treatments from home. So we need to be present here. The patients, how are we keeping them safe? Our physicians did do rotation. So there was always a physician here in the building so we could continue to treat patients. And the fact that a lot of patients were changed to a telemedicine reduced the number of contacts that our treatment patients had when they came into our facility. They were kind of sometimes the only patients here. So their exposure to other patients, other infections was kind of limited, which was a good thing. It did impact the scheduling of procedures in radiology, a lot more coordination, a lot more communication now, because again, limited number of patients in allowed at a time. And then what do we do with vaccines, such as a COVID shot? So we did reach out to our infectious disease department and really had a big consultation between the physicians, the nurses, and infectious disease. What do we do about that? And so we did get recommendations, came up with a protocol for that also, as far as receiving different vaccinations, including COVID. So that was one of the challenges that we met. On top of the shortage, now we had the pandemic. We continued to treat throughout it. And when we are done our 6 treatments, we removed those nephrostomy tubes. But during the pandemic, where we had limited staff to be available to interventional radiology, our physicians removed them themselves here in the office. So that was a big help. We were still able to keep the patients on track. They just didn't have to make another appointment at another facility to have their tubes removed. So we did adapt to it and we did pretty good. As far as the pandemic, everyone having to be in full gear, we already do that anyway. We do these treatments intravesically. We have a very robust intravesical therapy clinic that runs 3 days a week. We treat about 70 patients a week. So we're already in full protective gear. So that really didn't change.
Obviously, the procedure itself in normal times is complex enough. And then, as you said, layering any other additional challenge, whether it's a drug shortage or a pandemic, you have to be able to adapt. And so for this very complex procedure, on a great day, there needs to be some guidance. So you've developed an institutional guideline for how you conduct this process at your institution, Fox Chase. Can you tell us a little bit about how you created that and some of the steps to implement it across all of these various teams?
I'm going to bring up our manager, Rebecca. She spearheaded this whole development of this protocol. She has a lot of knowledge she brought. She has a lot of context. She was a transplant coordinator, so she knows people in nephrology. So we really relied on other people too. So we coordinated with the nurses, physicians, our clinical pharmacists, our nursing research team. We reached out and did literature searches for evidence-based best practice. And I can tell you there wasn't a lot out there. So we've really, really had to think about what we wanted to do, how we wanted to accomplish this, and do it safely. So really just pulling what literature was there and talking with people. Our physicians actually reached out to their colleagues around the country. Has anyone done this? Getting little bits of information, but really just looking at best practice and then coordinating that team. It's a very cohesive team. The nurses, the doctors, the pharmacists, the nursing research team, to really just get the information we needed to be able to develop this protocol. The other thing I can say is, looking to your professional organizations. So that's another thing. Look to ONS, look to the other professional organizations, go onto their message boards, network with people. My experience is going to conferences themselves, like at ONS, talking with different people outside of the lecture halls. You get so much information. I've yet to go to a conference, come home and not bring something back to the team outside of the lecture hall. So networking with other professionals. And when you have something new, sharing it with other people, going to conferences and sharing it, or a podcast like we're doing now, sharing what we've learned, what we've developed, how we did this with the rest of our community.
I love that. And I completely agree, especially for things that are either very new or just rare or unique or just not common. It's that the first time someone does it, that feels very scary because you don't feel like you're familiar with it. And so for these types of procedures or things that are just not as easy to connect with people. Like you do need to reach out across the country, across the region, wherever you are, and just understand what can you learn from those that have gone before you, that have done it before. And as you mentioned, sharing what you've done, if you've done it and you've done it successfully, is to share or not. I mean, I think it's not just the successes we need to share. We need to share the challenges, the failures, the concerns, so that we can all learn from that and do better the next time. And as you said, sharing that, whether that's officially publishing, posters, abstracts, going onto your community forums and sharing, here's what I did, here's how we did it at our institution. It's just so important to keep that information flowing and adding to that body of literature so that we can all kind of just piggyback on the efforts of those that have already gone through it for the first time.
And I do think I mentioned before we started with our first treatment, we did have a huddle, and that huddle included nurses and doctors. How are we going to do this? How's it going to go? And then afterwards, reuniting and having a second huddle. How did it go? Was there something we can do better? Is there something they thought, hey, we should have this next time? So really just communicating with the team, the whole team, before and then again afterwards to see, was there something that went really well or something that maybe we could improve upon? Just communication, putting our best practice out there and how can we improve upon that?
And so did you have any of those challenges or sort of like, we can do it better the next time experiences? And how did you overcome them?
Again, communication. We did realize, again, being a satellite, that we didn't necessarily have everything we needed. The nephrostomy tube, did we have a bag for the patient to go home with if it's not going to be capped? Did we have the proper caps? We did have someone kind of on standby, like, oh, we don't have the cap to put back on the nephrostomy tube when they're done. So, again, we're 4 blocks from the hospital, run over to interventional radiology, bring it back over here. So by the time the infusion finished, we have that now. We really prepared well. We really worked hard at this and thought through what could possibly go wrong, do ahead of time to make sure that it doesn't hit the patient, reach the patient. I have to say, we were pretty proud of ourselves when we were done, that we had thought it through, kind of ran through, a dry run. And, we were nervous. I'm not going to lie. We weren't lackadaisical about it. We were nervous. We had never done this. And there's not a lot out there on this. And to be one of the first ones to do it, it was exciting, but also nerve-wracking. Just not letting the patient see that, letting them know, you are our first patient, but we're all educated nurses. We're all experienced nurses and the doctors are here. So not to toot our own horn, but we actually did really well. We did really well.
I love the pre and post, kind of like the debrief, the huddles before and after. As you kind of said, maybe like a dry run or a simulation, walking through it, walking through the steps, and not only like just in mentally what's going to happen, but sometimes it's a physical. Where are we physically going to be? What side of the bed or the chair will you be on? Some of that is really necessary to make sure that you just don't overlook something.
To expand upon that, so at the time we did our first infusion, our first patient, we had 2 rooms with a stretcher, and they were actually our procedure rooms, and that's where we did our treatment. So we didn't have a lot of space. We had 2 basically bays in which to treat. We had to make sure we had the physical space layout. Where are we going to do this? And think about the time that the patients are going to be there. Each visit, approximately 2 hours. By the time they come, we do the assessment, get them hooked up, then do the flush, kind of, get the patient back together before they leave, ask if they have any questions. It's about 2 hours. You need to make sure you have that physical space and somewhere the patient can be comfortable. They're going to be in the same position for about an hour. We want to make sure that they can recline back on a stretcher and, not really sit in a chair. And, do you have the IV poles? Something as simple as that. Do you have that readily available? But again, do you have that physical space layout? So the patients come in and be as comfortable as they can without too much movement. So even just that physical space, making sure that that's prepped and ready to go.
So Chris, what advice would you give to nurses who may be creating a similar guideline or wanting to explore maybe being able to do this type of procedure at their own workplace?
The first thing I would say is to do a literature search, see what's out there, what evidence-based practice is out there, best practice. There may not be anything, there wasn't much for us. There is now, but also to network, to, again, reach out to the professional organizations, look at the boards, what is out there, presented out there, look at their information boards, go onto the blogs, says, has anyone done this? And really just see what's out there, use your networks, use your contacts. Who do you know who may have done this, who might know someone who has done this? Really use your contacts. I think that's a big thing. And I think with the professional organizations we have, I keep saying ONS because that's a big one. So many members of ONS reach out to that community. Look to your nursing researchers. Where can I go for this? And really, again, most important, communicate, reach out to your coworkers, reach out to your members of your oncology society and see what's out there. What have you done? How can we expand upon that or improve upon that and sharing information? So we readily share this. We were at a conference and we shared this. We shared our protocol. Here's a copy of it. Take it with you. Make it as easy as possible for people, for other colleagues to get this information.
I love it. Well, Chris, thank you so much for joining us on the podcast today. It's really been a wonderful conversation. I've truly learned a lot. I think this is something that many oncology nurses don't ever see maybe in their practice or very rarely. And so being able to hear from you who've done a deep dive, who live and breathe this every day, really helped bring it to life. And so I really appreciate your time. As we get to the end of the episode, we'd like to always run through just a few quick questions just to help summarize some of the great things we've talked about. And so the first one I want to ask is, what are some of the misconceptions or maybe sort of implicit biases that we as healthcare professionals might have just about upper urothelial tract disease and its treatment? And how can we evaluate maybe some of those hidden biases or misconceptions that we hold?
I did talk about this with the physicians too. What are our biases here? And one of them, the biggest one, is that you can't think of this as the same as being bladder cancer. So this is in the upper tract. We can't approach it as if it was non-muscular invasive bladder cancer. It's in the upper tract. It has to be approached different. The diagnosis is different. It's harder to diagnose. Again, we're not visualizing in a routine office cystoscopy the ureters. Evaluating, make sure you get the proper testing. Again, harder to diagnose, not the same as bladder cancer. And you can't treat it or even resect it out. When I was talking to our surgeon, he said, you can't resect the urothelial disease in the ureters like you would in a bladder tumor. You can't go and just pick it apart. It's a little bit more complex than that. You can't go in and resect out lesions in the ureter itself. So again, changing your way of thinking. This is not bladder cancer. We have treatment for bladder cancer, but how can we adapt it to reach the upper tract? And that's what our physicians did. They thought, we have really great treatments for bladder cancer, but how can we get these treatments to reach into the ureters? And so they thought about it and they talked about it and included us in that conversation. That's when they decided, let's try treating it from above. Can we do that? It's not the same as bladder cancer. It can't be treated the same as bladder cancer. It can't be diagnosed the same as bladder cancer. So really just, building a knowledge base and going from there.
And what additional training or education would you recommend for oncology nurses that want to learn about this topic and stay current on how things are changing in this administration technique?
Going back to the professional organizations, the publications, going to conferences, reaching out to the colleagues in the oncology community. Here at Fox Chase, our nurses that do treatments, we're all chemotherapy certified, keeping up with that, making sure we have all of our mandatories. This is included in there. As it's just a mandatory for just being a nurse at Fox Chase. One of the mandatory educational sessions every year is chemotherapy safety, talking about oncology. We have to keep up with our oncology credits, and that's kind of being a Fox Chase nurse. That's expected, that you continue to educate yourself, that you keep up on the education. But then again, it's independent. If you want to do this, getting your oncology certification is great, but we're also chemotherapy certified. So getting that extra knowledge base to really make sure that we are proficient in what we're doing, keeping up with the education.
And then finally, what are some additional resources that you would recommend for healthcare professionals or for patients who we want to learn more, we want to share more information?
We direct our patients to use the internet, but use it cautiously. There are some bladder treatment websites, like BCAN is very good. It's a bladder cancer network. It's for patients and also for professionals. And that is a good one. So really using the internet wisely, gathering information. There's a lot of information out there, but also getting that information and then bringing it to your healthcare team to have them decipher it. Is this accurate? Is this something I should be looking at? Is this something that you think holds true for me? But I do think there's a wealth of information out there, not on every topic. And so that's why it's important to think outside the box like we did here. What can we do differently to treat these patients? And then making that information known, putting it out there. But there are some really good websites by the Oncology Nursing Society, by the Cancer Society, the American Cancer Society, using reputable websites to get information.
Well, Chris, thank you again. It's been great talking with you. I've learned a whole lot about this topic that truly I was unfamiliar with. And so I know that our listeners will likely feel the same. So thank you again for your time and sharing all of your experience with us on the podcast today. Do you have any final comments to share?
I've been a nurse at Fox Chase for a lot of years, and getting the chance to do something new and something different, it's exciting. The world of oncology is always growing, always changing. For us to take advantage of that and not hesitate to learn new things, this really benefits the patients. And to do something new is, I think, a great thing. Things are changing so quickly. We need to keep up and we need to be up to date. I'm excited to be in this oncology world. It's always just keeping up on education, what's new out there, just really sharing your information. I'm excited to be doing new procedures with patients. And I think oncology is a specialty. It's not a patient you see once. These are patients we see for the long haul. We get to know them really well. It's an exciting field. I'm proud to be part of it and to be part of this institution that I work at now. I couldn't be prouder.
Wonderful. Well, thank you again, Chris, for joining us today.
Thank you.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.